My name's James Turvill. I'm a consultant gastroenterologist. Here at York Hospital we have considerable expertise developed over a number of years in using a biomarker called Faecal Calprotectin. In recent times I've been working with the Yorkshire Humber Academic Health Science Network to devise and implement a care pathway for use in primary care. Today I'd like to talk to you about a little bit about Faecal Calprotectin, the evidence that we've accumulated to help us devise this care pathway, and then most particularly to talk you through how you in primary care will use that pathway. So calprotectin is a stable protein contained within the cytoplasm of neutrophils. In the context of intestinal inflammation, whether that be the small or the large bowel, neutrophils migrate into the gut wall, into the mucosa, where they degranulate, and in so doing they shed calprotectin into the intestinal lumen. This calprotectin within the lumen becomes incorporated into stool and then can be detected by an ELISA after defecation. The calprotectin is stable for a number of days, and so this is a straightforward laboratory technique to perform. It's implicit, therefore, that the amount of inflammation going on within the intestine, whether it be large or small bowel, correlates to the amount of calprotectin that's detected by this assay. And indeed, calprotectin has become a surrogate or biomarker for intestinal inflammation. This makes it potentially extremely useful, and of course that's why we're interested in it. In the context of inflammation within the intestine, the calprotectin is raised, and we see this most particularly in inflammatory bowel disease, that is Crohn's disease and ulcerative colitis. But the calprotectin will also be elevated in gastroenteritis, for example, caused by Salmonella or Campylobacter, by diverticulitis, by certain drugs, by ischemia, and often, in fact, in cancer as well. The flip side also applies, and in non-inflammatory conditions, that is, symptomatic conditions caused by functional disorders, that is, notably the irritable bowel syndrome, we would expect the fecal calprotectin to be normal. Now, primary care has a good deal of difficulty at times distinguishing inflammatory conditions from the irritable bowel syndrome. A great deal of time and money is spent in secondary care in investigating and managing patients with the irritable bowel syndrome. And if these patients could be identified within a primary care setting where there are management strategies available to them, there's the potential for improved clinical and cost effectiveness. And this is where we hope calprotectin will apply. And this is where we've been interested in finding a use for it. So if we can get the use of calprotectin right, it can become clinically and cost effective. NICE have recognised this and issued guidance, which is outlined as presented here. Faecal calprotectin testing can be used as an option in adults with recent onset of lower gastrointestinal symptoms for whom specialist investigations are being considered if cancer is not suspected, and it is used to support a diagnosis of IBD or IBS. The problem with this guidance is, as is always the case, the devil is in the detail. And in truth, there has up until now been very little evidence base to support a structured program for applying this guidance. Faecal calprotectin has a very high negative predictive value. It's a great rule-out test. The standard cutoff for faecal calprotectin is 50 micrograms per gram. And if a symptomatic patient, a patient with lower gastrointestinal symptoms, has a calprotectin less than 50, they and their doctor can be extremely confident that they have a functional disorder, an irritable bowel syndrome. So it's a great rule-out test. The problem is that the fecal calprotectin generates a number of false positives. In fact, can generate a significant number of false positives. The test is perhaps akin to the D-dimer for venous thromboembolism rather than the troponin for myocardial ischemia. So you can rule out, but it generates false positives. Its positive predictive value is poor. This problem is particularly intense in primary care, where the point prevalence of inflammatory bowel disease is so small. It's perhaps 3%, whereas many of the studies that supported the NICE guidance have a significantly higher point prevalence. As a result, if fecal calprotectin testing is brought into primary care, the risk is that we create more referrals into secondary care than already exist because of the high number of false positives that are generated. This therefore would result in a reduced cost effectiveness and a reduced clinical effectiveness in applying this guidance as compared with standard practice. So, being aware of these risks in primary care, we've looked at the efficacy of fecal calprotectin at York Hospital and devised a care pathway that we think builds on the strengths of this biomarker, and then we've piloted it. And I'd just like to take you through some of that data in the first instance. So retrospectively, we looked at 500 secondary care referrals to York Hospital, all of whom had a calprotectin less than 50, and we found a negative predictive value for functional disorders, that is the irritable bowel syndrome, in 96 or more %. The calprotectin was falsely negative in the sorts of diseases that you expect to cause gastrointestinal upset, but in the context of no inflammation. So we saw it in bile salt malabsorption, giardiasis, microscopic colitis, celiac disease, chronic pancreatitis, and so on. One Crohn's disease patient also was missed, and we need to be aware that the calprotectin is not a diagnostic tool, it's a risk assessment tool. It's able to nudge you in the right direction, but not provide an absolute diagnosis. Clinical review remains indicated. But this was our experience, and we felt it was important for us to be able to, and sufficient for us to be able to build on it. If we look at the flip side, that was our false positives, the patients who had a falsely raised fecal calprotectin. We saw that we could improve the positive predictive value, that is, reduce the number of false positives, by uplifting the fecal calprotectin cutoff from 50 through to 60, 75, and 100. And we felt we could get the balance right in retaining a high negative predictive value and yet uplift the positive predictive value by altering the cutoff from 50 micrograms per gram to 100. And based on this, we developed a care pathway with a traffic light system using one cutoff at 100 micrograms and another at 250. This pilot was supported by NICE and by the Vale of York CCG, and we rolled it out over a 6-month period in 5 general practices across the Vale of York. This table summarises the distribution of fecal calprotectins in that pilot and the outcomes. GPs were encouraged to use fecal calprotectin testing as they felt clinically appropriate after baseline investigations had been performed and when there was diagnostic uncertainty as to whether the patient had inflammatory bowel disease or the irritable bowel syndrome. And we repeated the test when the calprotectin came back in the intermediate zone. So we had 3 groups of patients: those with a fecal calprotectin less than 100, those with a fecal calprotectin greater than 250, and those with a calprotectin in the intermediate range, 100 to 250. Those with a high fecal calprotectin, that is greater than 250, went straight to a colonoscopy, and there was a high instance of inflammatory disease in that cohort. those with the calprotectin less than 100 were treated initially in primary care as if they had the irritable bowel syndrome. If they were still symptomatic after 6 weeks, they were referred to secondary care. And we found, again, a high incidence of functional disorders of the irritable bowel syndrome within that group. And then the intermediate group were treated by routine referral. The graph, I think I just want to show two key pieces of information from it. The first, if you can see, is that the almost all of the patients with the irritable bowel syndrome had a calprotectin less than 100. There were relatively few false positives generated. There were some, but relatively few. So this immediately made us think that this was a more cost-effective and yet safe model. And the second was that the findings of inflammatory disease, what we described as organic enteric disease, increased through the ranges less than 100 up to 250. So less than 100, the incidence was 3%, whereas greater than 250, it was 54%. We felt this reflected the right balance of risk in devising a pathway that was had utility and built on the strengths of calprotectin. So when we look at the negative and positive predictive value of the care pathways, we applied it and compared it with the standard cutoff of 50 micrograms, we saw no significant loss in the negative predictive value, but we doubled the positive predictive value from 20% to 40%. And we felt that we could work with this. And based on these findings, I worked with the AHSN to develop a revised care pathway, and it's that I'll now discuss with you and take you through, because it's that I want you to, I would hope that you incorporate into your clinical practice in primary care. So this is the algorithm that we'll follow. It's a little complicated. This is available to you on various packages already sent through to your practice, but I'll talk through it in more detail. There are a number of important initial points to just talk you through. The first is that this turns on supporting clinical judgment and clinical uncertainty. The second is that the fecal calprotectin splits at 100. So we don't use the old 50 micrograms cutoff, we split at 100. The second important thing is that if the test comes in at 100, we repeat it. The third is that those who have a persistently elevated calprotectin, that is greater than 100, are divided once more along the 250 microgram cutoff. Those having a repeated calprotectin greater than 250 go straight for colonoscopy, and those between 100 and 250 on repeat are referred routinely because of the lower likelihood of there being inflammatory disease and the relatively higher percentage of false positives even in this group. Lastly, the care pathway recognises the fact that gastroenterologists need and indeed want to be seeing patients with irritable bowel syndrome. This is part of our service, and many patients with irritable bowel syndrome have symptoms that are very challenging that need to be shared beyond primary care. And so there's an option for review of patients who may well or likely have the irritable bowel syndrome, so that an option for referral can still be made. And this closing the loop, this backup, I think is very important. So I'll talk you through it in more detail, but I hope you'll find it intuitive. Indeed, the pathway is specifically designed to be straightforward and to apply to your own clinical practice, and, as I say, to be intuitive. The care pathway recruits, the care pathway should be applied only to individuals aged 18 to 60. And these patients are presenting with lower gastrointestinal symptoms, typically a change of bowel habit, bloating, perhaps abdominal pain. You should investigate these patients as you judge clinically appropriate in the first place. Then you add on the calprotectin. Where and when you add it on turns largely on the symptoms and your assessment of the patient. In the pilot, a good number of patients had bacterial gastroenteritis, and these, of course, those illnesses generated a positive calprotectin. If someone is presenting acutely with diarrhea, you should send a stool culture first, or for Clostridium difficile, and only if that's negative would you then request the fecal calprotectin. The key to its use is when there's clinical uncertainty. If you're sure of the diagnosis, there's no point in using it. If you're uncertain of it at any stage of your care of the patient, then it should be applied. If you're certain the patient's got the irritable bowel syndrome and you're happy to treat them, that's fine. If you're clear that they've got inflammatory bowel disease and need to be referred instantly, of course that's fine. But where there's uncertainty, that's where you apply it. And you can conceive of a number of scenarios, for example. A patient may have typical irritable bowel type symptoms, but may have a family history of inflammatory bowel disease, or intense right iliac fossa pain that you think is out of proportion, or may have a little nausea, or may have developed an iron deficiency, which is probably nutritional or menorrhagic, but you don't know. Or the patient may have had long-term irritable bowel symptoms, and then new symptoms come along that may be part of the same process or something slightly different and you're not quite sure. Or someone perhaps has a little bit of bleeding that's likely to be anal canal bleeding in the context of an irritable bowel syndrome, and trying to risk assess in that context may be difficult. It can also be helpful in excluding GI disease where you think this may be urological or gynecological. And so it helps sometimes give a steer as to whether pelvic pain is, it gives us a steer as to whether you're thinking of the right system when someone may have, for example, pelvic pain. It's important not to use calprotectin if you suspect cancer. If you suspect the patient has got cancer, whether or not they fulfill the fast-track colorectal referral guidelines, you should be referring the patient to a colorectal surgeon. But where there's uncertainty and you think that the test can help either in forming a diagnosis or in defining a management plan, then use the test. Sometimes you have situations where you're confident of the diagnosis, but the patient is not and feels that the symptoms are too intense to be explained by a functional disorder. And occasionally a test like this can help copper bottom the diagnosis and allow you to move forward with a management plan. Similarly, I would not expect you to be making referrals into secondary care without the test having been requested, because by implication there is some uncertainty as to the diagnosis. So I'll just talk it through briefly. It's very straightforward. We have developed system templates, that is System 1 and EMIS templates, that are available in your general practice that will take you through this guidance as well. The first situation is when the patient has a fecal calprotectin of less than 100. Here, there's a high likelihood of an irritable bowel syndrome. You should give that diagnosis positively to the patient, reassure them, and treat them as NICE direct. There are links on the algorithm to the NICE treatment pathway. You should consider alternative gastroenterological, that is, alternative non-GI diagnoses, as I've just mentioned. Urogynecological disorders might give similar symptoms, and a normal calprotectin may give you the lead on this. Treat the patient and review at 6 weeks, and this is when you decide how and in what way to close the loop. If the patient is young, that's less than 50, and their fecal calprotectin was also less than 50, but they're still symptomatic, their chance of having the irritable bowel syndrome is still extremely high, and you should treat them with second or third line IBS therapy before considering a referral to secondary care, secondary gastroenterological care. If, however, the patient is older, that is 50, or had a fecal calprotectin greater than 50, that is between 50 and 100, and they're still symptomatic, refer these patients routinely. This is the group in whom there's a small but increased risk of these other non-inflammatory GI disorders. Looking at those who have a fecal calprotectin greater than 100, the first thing to do is to repeat the test. This is important. Those who have a fecal calprotectin less than 100 on repeat, you treat those, as I've just outlined, as if they have the irritable bowel syndrome. Those who have a fecal calprotectin between 100 and 250, you refer routinely to gastroenterology. And those who have a fecal calprotectin greater than 250, you refer urgently to gastroenterology for a straight-to-test colonoscopy. You need, in that referral, to give sufficient information to make that straight-to-test colonoscopy safe. Drugs, past medical history, comorbidity, and the like. But these are usually young patients. And that's it. That's the long and the short of it. It's hopefully for you an intuitive, straightforward test to pathway to apply. You use it as you see fit, and is directed by clinical uncertainty, and the cutoff in broad terms is 100 with review. So to assist in this implementation and to allow it to embed as speedily and as painlessly as possible, we've worked quite hard to support you and indeed to evaluate the implementation. We've worked with the Commissioning Services Unit, now Embed, to devise management system templates, both System 1 and EMIS compatible. These will have been sent to your surgeries and can be downloaded and then used as you prompt them, and indeed they will support you through the patient consult. We've worked with the laboratory, who will issue guidance based on the fecal calprotectin results compatible with this care pathway. We've published a patient information leaflet and GP information leaflet. And I'm the backstop, so to speak, if you have any queries or concerns in helping you to run this tool out. The key for you, I think, to remember is to use it as a risk assessment tool. Fecal calprotectin supports your judgment. It shouldn't take it over, and you use it when you feel you need that support. Lastly, we're going to evaluate this implementation in some detail and, if necessary, improve on it. Thanks to the AHSN, we've got support from the York Health Economic Consortium, and they're going to perform a formal health economic evaluation of the implementation. So finally, I'd just like to thank the Yorkshire Humber Academic Health Services Network and my own trust, York Teaching Hospitals NHS Foundation Trust, for their support of me in this programme. Thank you.